All right, good afternoon, everyone. My name, for those of you who don't know, is Anand Jain, and I'm an assistant professor in the Division of Digestive Diseases and director of the Esophageal Disorders program here at Emory. I'm honored today to introduce Dr. John Pandolfino, professor of medicine and chief of the Division of Gastroenterology and Hepatology at Northwestern University. Dr. Pandolfino obtained his medical school degree from Loyola University and completed internal medicine residency and gastroenterology fellowship at Northwestern. He then joined faculty in the Division of Gastroenterology at Northwestern in 2001, where he has served as director of the Esophageal Center and as chief of the division since 2013. Dr. Pandolfino is the single most influential figure in the field of esophageal motility disorders in the past 2 decades. He's the chief architect of the Chicago classification system, which is the scheme used around the world to define esophageal motility disorders. His other seminal contributions to the field include identifying the currently known achalasia subtypes and variants of esophageal spasm, including coining the term jackhammer esophagus. He has also pioneered a paradigm-shifting new technology called the functional lumen imaging probe, which allows for an accurate evaluation of esophageal motility disorders entirely during upper endoscopy. Dr. Pandolfino has nearly 200 original research publications, has held continuous NIH R01 funding since 2009, and was awarded a program project grant in 2018 for his work. Dr. Pandolfino is truly the father of modern esophagology. As a young esophageal physiologist, I can attest to the fact that Dr. Pandolfino's work either defines or in some way impacts every single aspect of clinical and investigational esophageal physiology. I'm incredibly fortunate to have Dr. Pandolfino as a personal mentor, and I'm honored to have him share his wisdom with us today.
Thank you very much. Wow, that has to be the single best introduction I've ever had in my life. Wow. So, well, I don't really need to introduce myself too much. Anand did a great job of doing that. And once again, I'm truly humbled actually to be here at Emory. Emory's had a long historic, kind of really, in my mind, one of the big centers in the esophagus for many years, going back to the surgical days and also the interactions with GI. So really a lot of great work has come from Emory in terms of the esophagus. So it's an honor for that. And what I'm going to try to do today is to make something that's some people think is boring, kind of a little bit fun and exciting. And I think, a lot of people think gastroesophageal reflux disease, is a pretty simple disorder that you treat with PPIs and then you're kind of done with it. And hopefully I'll put it into the context today in a paradigm that you guys all understand that it is a lot more complicated than that. It's interesting because I always talk about, how I got into the esophagus. I thought I was going to be an orthopedic surgeon when I was in medical school, and I did a lot of rotations in orthopedic surgery. I liked sports and I liked medicine, so it seemed like a good combination. But then, one of our hip fracture patients went into AFib, and none of the orthopedic guys wanted to look at the EKG, and I thought that was crazy. And I said, I don't think I could practice medicine if I didn't think about those things. So I quickly made a shift over to internal medicine, and really has been very happy with that. And how I actually got in the esophagus was really kind of how I chose my mentor. I was in GI, I liked GI, I liked doing procedures. I also liked taking care of patients. I like thinking about technology and diagnostics. And I was fortunate enough to run into Peter Karillis, who was an esophagologist, and really worked with him. And that was really the start of my career. But it was interesting because when I went back home, and I'm from Brooklyn, New York, and I was having Christmas dinner with my family, I found out that I was really someone who stayed in the family business. I come from a long line of plumbers. In fact, 50% of my family are plumbers. So I was notified by my Uncle Tony that I actually stayed in the family business, because literally what I do is plumbing. I stop backflow and I, try to get things moving through the pipes. And that's really what this is all about. Now, in terms of my title today, Personalized Management of GERD Using Precision Medicine to Tailor Therapy. A lot of people, when I show them that, they're like, personalized medicine, precision medicine in GERD, what are you talking about? And, I think it's important to go back to where my conflicts are too, because there's a lot of different conflicts here. And the conflicts are focused on different therapies and also different diagnostics. So obviously, if there are all these different therapies and different diagnostics, it's not a one-size-fits-all disease, and I think that's kind of important. So really what I want to do today is I want to kind of discuss the heterogeneity of GERD, and specifically GERD patients, and really prove that this is a much more complicated disease than it is thought of. And really, when you look at it, is you have to take all of these important clinical and physio markers to really think about the disease entity to treat the patient appropriately. And really, in the end, what I'm going to try to present to you is a personalized approach to managing refractory GERD, but really also talk a little bit about the paradigm of personalized medicine across all subspecialties. So what's the definition of personalized medicine? If you look it up in Wikipedia, you know, and online, this is kind of what it says. But really what it's saying is that you're taking information, you know, whether it's a sign or a symptom, you know, a biomarker, pharmacogenomics, and then you're using that to tailor therapy. But it was interesting because the first person to really talk about personalized medicine was Hippocrates, you know, about taking good physical signs, an exam, thinking about the patient and the complaints, and really putting it together. And I always think it's kind of funny that precision medicine, P4 medicine, has gotten all this hype, but this is really something we all should be doing. And that being said, I think, you know, the oncologists who, especially with chemotherapy and targeting chemotherapy, have really took ownership of this particular title, but it literally goes across the spectrum. And why do you need personalized medicine? Well, I think you need personalized medicine because it's the best thing for each individual patient. Most of the time you find the right answer. You save money if you do it the right way. You'll save time for the patient because you'll diagnose these patients up front, and you'll give them the exact treatment to effectively treat the thing that's going on. So you may even cure these people. And really that gets to the heart of GERD. Because when I think of a GERD patient, I don't think of them, okay, you have reflux, you have heartburn, I'm going to give you a PPI and you go on your way. I think about their symptoms because the symptoms are heterogeneous. I think about the response to PPI therapy because that'll tell me something. I look at their anatomy, their physiology, and then the other thing that I think is really important is considering their psychosocial stressors. So these are the 5 components that I really delve into when I start to think about a personalized approach to GERD. Now, when you look at the definition of GERD, and if you've ever been to a GI talk on GERD, you'll probably see this slide. This is what we call the Montreal Consensus. And I'm not a big fan of that definition of what reflux is. It seems a little complicated for just saying that, you know, you develop symptoms or complication from movement of gastric juice above the EGJ. But the thing I like about this definition is it really shows you the heterogeneity of the presentations. So much to the point that you break it up into esophageal syndromes and extraesophageal syndromes. And then these symptomatic esophageal issues, and then issues that have a causal relationship or a proposed association. And when you look at this list of these signs and symptoms and complications, it's kind of illogical to think that we would treat everyone the same way and they would have the same response. You know, I'm not going to treat the person who has Barrett's metaplasia the same as I would someone who's got recurrent aspiration and then may have pulmonary disease or develop pulmonary fibrosis from that. So you have to think about all of these symptom complexes and think about the various presentations that may bring them to your office. Now, this is a very simple algorithm that's typically used. It's actually an algorithm that's actually European in nature. And really the reason why I use a European algorithm is because in the United States, if you use anything above a single dose PPI, that is off-label. There's no FDA indication for double dose PPI. So when you improve or you escalate PPI therapy, that's an off-label indication. You should be telling your patients that, but about 40% of prescriptions are written for double dose, and I think a lot of people probably don't say that. But the long and short of it is that there's no problem with giving someone an empiric trial of PPI therapy. So if someone comes in with typical symptoms of heartburn or regurgitation, and they don't have warning signs like dysphagia, unintentional weight loss, evidence of GI bleeding or anemia, then those are patients that you can treat empirically. You don't have to get an urgent endoscopy, and you can see how they do. Now, a lot of the algorithms say you have to treat these patients for 8 weeks, but I will tell you that if someone's going to get better, they're typically better in 2 to 4 weeks. They usually notice a response. It doesn't take them 8 weeks to get that full response, and waiting 8 weeks and then asking them whether they're better may be a little bit long to wait. I mean, if you're not sure what the diagnosis is, do you want to wait 2 months trying to figure this out with this empiric trial? Because empiric treatment is really guessing. So, you know, when you tell your patient, I'm going to give you an empiric trial of PPI therapy, that sounds a lot more fancy than saying, well, I'm guessing that you have reflux, and I think or I hope that this medicine may work. Now, if they don't respond to PPI therapy, the other thing you got to think about is non-compliance. It's so interesting that patients who continue to have symptoms who are on PPI therapy don't take the medicine appropriately. So in fact, one of the worst consults that I'll get is someone who has refractory heartburn, and then they come to my office and they're telling me they're taking their omeprazole on an empty stomach before they go to sleep. That medicine is essentially worthless. So they haven't even had an effective PPI trial. So if you look at it, about 50% of people actually don't take their PPIs appropriately. So once again, that's an easy fix. And that's something they shouldn't have to come into the GI doctor's office. We need to do a better job at explaining this, providing them with educational material so that they take this medicine appropriately at the right time. Now, if they don't respond to compliant therapy, then we consider them a failure. You can improve acid suppression by either upping their PPI dose as a single dose or splitting it to BID. I prefer to split it into BID because you certainly get better bang for your buck in terms of acid suppression. I think we'll talk a little bit later about the hierarchy of PPIs. Not every PPI is not the same. In fact, if you look at how effective they are in terms of acid suppression in the stomach, there's a huge range of effectiveness in terms of these PPIs. So much to the point where, you know, you'll be surprised at what level of acid suppression you get with pantoprazole. Now, if people don't respond to an escalation of PPI therapy, and I think all of this can be done in primary care. It does not need to be done with the supervision of a gastroenterologist. But certainly if people are taking double dose PPI and not getting better, that's when you send them to a specialist and where they can get better testing and more diagnostics to better phenotype the patient. Now, the other thing that's important to remember is that although PPIs are a great medicine, and I will say this again, PPIs are a great medicine. They revolutionize our ability to take care of acid peptic disorders, GI bleeds, reflux. They've actually replaced surgeries. So anytime a medicine replaces a surgery, that's actually a really big thing. So PPIs are very good medicines. But that being said, inappropriate PPI use is a bad thing. They're expensive. They kind of shift the microbiome a little bit, and we don't really know what they do to people totally in 10, 20 years. We know that for the most part, they're pretty safe. And a lot of this stuff that you're hearing in the press about dementia, cardiovascular disease, chronic kidney disease are probably overblown. And when you look at the prospective trials, it's not as big a risk. So we have standardized language for risk of PPI. And really what it focuses on, number one, is you have to have the right indication for a PPI. If you don't have a good indication for a PPI, then there's really not a great benefit. So the risk-benefit ratio is always going to shift in favor of risk. Once again, it's a costly medicine. People have to take it every day at a specific time in their life, so it affects their quality of life. So once again, although it's a great medicine, it's not perfect. And then actually, when you look at the symptom response, it's also not perfect. So you can heal esophagitis very effectively with PPIs. In fact, if you escalate the dose, 95% of the time you can get pretty good treatment effect with PPIs. But when you start looking at other things like regurgitation, it's less than 50% effective. Now, this is a paper from my mentor, Peter Karillis. And what it's showing you here is that the blue is the placebo response and the green is the yield above placebo response. So you can clearly see here that in this particular example, the yield of PPIs and regurgitation above placebo is very small. So it's not surprising that most people with regurgitation may not respond to PPI therapy. Look at what happens with hoarseness and chronic cough. Basically, don't work with PPIs. So you're not going to get a great effect with PPIs for hoarseness and cough. That being said, our ENT colleagues are the biggest prescribers of PPI therapy. Now, I'll tell you that if you have someone who has really bad heartburn, regurgitation, or hernia, and they also have sore throat and laryngitis, they'll probably get some effect from the PPI because they have significant reflux. But unfortunately, a lot of these patients are people who don't have objective evidence of reflux and come in with a sore throat or cough, and they're starting on these long trials of multiple different PPIs without any validation that it's truly reflux related. So the other thing that's important here is look at this chest pain group. Now, we know that the top 3 causes of non-cardiac chest pain are GERD, GERD, and GERD. It's not spasm, it's not jackhammer. Those are much more rare conditions. So if someone has non-cardiac chest pain, that is GERD until proven otherwise. And if it's not GERD, even before those spastic motor disorders, it's likely a functional chest pain. So kind of like functional heartburn, globus sensation into the functional realm. But look at that chest pain group. So this is not shocking, but it's really important. If you have a positive pH test and you give someone with chest pain a PPI, look at the response rate here. If you have a negative pH test, look at the response rate. So once again, this particular test is telling you that these people are going to respond. And there's really no way to know that and distinguish this by just giving them empiric trial. So you could be much more effective and precise in your management if you had this particular study done. And that gets back into the pathogenesis of reflux, because although it's deemed to be a disease of abnormal acid burden, it's really a compilation of multiple different things. And really how I like to think about this definition is really more of a balance between the abnormal reflux burden, and remember, it's not just acid, because bile and pepsin is still pretty nasty. And then it's your ability to tolerate that reflux. So what's your ability to not sense that reflux? We're refluxing all day, but we don't feel that. Reflux is a physiologic event, and it only becomes pathologic when we feel it. And what makes us feel it? Well, we may have visceral hypersensitivity, where there's maybe a neurologic threshold change for that stimulus, or there may be some cognitive or central mediated hypervigilance, where you start to feel things that your brain's trying to shut off. So really this balancing act is really kind of where we're at in terms of pathophysiology. And we've known this for a very long time. Basil Hershowitz at the University of Alabama many years ago showed that if you took 100 GERD patients and 100 normal controls, just asymptomatic patients, and measured their gastric acid secretion, it's the same. So this is really not a disorder of acidity of gastric juice or acid clearance. It's really a disorder of delivery of this reflux burden into the esophagus, and then how we deal with this from not just a peripheral level in terms of sensitivity, but also a cognitive level. And if you look at why PPIs fail, PPIs don't fail because they don't reduce acid. They're very effective at reducing acid in the stomach. They fail because they don't affect or change the things that are driving the pathogenesis of reflux, which are really the anatomy and the physiology of the esophagus and this hypersensitivity. And that's really where they fail. And if you're going to treat reflux that's refractory to PPI therapy, you have to focus on reducing reflux events and improving tissue sensitivity. The other main reason people don't respond to PPI therapy or have refractory symptoms is that they just don't have reflux. In fact, 50% of the people who are on a PPI who think they have heartburn and regurgitation and are taking it for that don't even have reflux disease. And it's a pretty amazing. So if you think of the cost burden, now remember, PPIs cost us over $10 billion a year. And to think that maybe not all those people are on for the indication of reflux, but if say $5 billion are spent on reflux, by just identifying the right people, you could save over $2.5 billion. Think about the cost effectiveness there if we just were more precise in how we manage these patients. Now, when I say anatomy, I think it's really important because I think a lot of even gastroenterologists don't appreciate the flap valve. So at the end of the esophagus, the top of the stomach, you have a valve. And that valve is a very complicated valve that is a hodgepodge of your intrinsic lower esophageal sphincter, your crural diaphragm. So your diaphragm actually acts as an extrinsic sphincter. And then you have these phrenoesophageal ligaments and these anatomical changes that create this beautiful flap valve. So when you actually have an increase in intra-abdominal pressure, it actually closes itself, and then this sphincter will actually compress to prevent reflux. And as you get further and further along, whether this is due to obesity, abdominal trauma, or pregnancy, you start to efface this flap valve and you start to develop a hiatus hernia. And this is a very important staging or classification scheme because this will actually dictate what type of intervention I will proceed with, whether I will decide to go with an endoscopic procedure potentially, or even a surgical procedure, and what type of surgical procedure. And I think this largely gets ignored. And in fact, sometimes it doesn't even come into the decision as to what operation or what procedure a patient will actually get. And I think that's a big mistake. because there are many people that may be candidates for a lesser or less invasive procedure if you actually have a better idea of their anatomy. And some patients will actually need a more aggressive treatment, and you can undertreat people if you don't understand that anatomy. So this was the Bravo capsule. And it's interesting because Pat Waring, who was here a long time ago, some people may remember Pat. Pat actually was involved in a lot of the initial studies we did with the Bravo capsule. And this is a really nice test because what it did was it allowed us to put a little capsule at the end of the esophagus. And we can actually measure acid exposure for 96 hours. And by doing that, we can now separate patients who need to come in for an endoscopy and the patient with GERD and without GERD. So this particular test is a little bit more expensive than having a catheter placed down your nose. But the thing that we get with this test is, number one, we get 96 hours. And number two, the patients don't hate us. Because if you put a catheter down the nose, patients are not going to be happy with you, especially when they need to walk out and live with that for 24 hours. It's a very horrible test. So this allowed us to now separate patients into abnormal acid reflux burden or normal acid reflux burden. So when I see a patient comes in with heartburn and I see this particular tracing, and this is the pH tracing over the 96 hours, where they have minimal pH tracing levels below 4, this person is normal. This person does not have reflux. They don't have acid reflux. They don't have non-acid reflux. They just don't have reflux. So if their main complaint is functional heartburn or heartburn, and this is their study, they'll leave my office with a prescription for hypnotherapy. Not more PPI, not more surgery, hypnotherapy. So that is actually a very effective treatment for functional heartburn. So really, this allows us to be more precise in our treatment approach. Now, we do have more fancy tests. So this is something called pH impedance. So what we can do with this particular test is not just measure the pH here, which you see in red, but we can also tell whether or not the reflux events are liquid. And this is what it looks like in this particular system, this white color. We can actually see the reflux events. And I can see whether they're liquid, whether this is a belch, whether it's a mix of air and liquid, how high it goes up, whether it's correlated in terms of the symptom reflux correlation. It also tells me how well the stomach is suppressing acid. So this particular tool I use a lot less often, but only when I'm trying to figure out why the PPI is not working in someone I know has reflux disease. So if you have esophagitis and I treat it and it heals and people continue to have symptoms, or you have long segment Barrett's esophagus and I'm trying to figure out why you're still having symptoms, or you may have had a positive wireless capsule test and I still can't explain why you're not responding to the PPI therapy, then I will do this test because this will tell me whether or not the acid is being suppressed appropriately, because there is a very small patient population that hypermetabolize PPIs. About 5% of the Caucasian population actually hypermetabolize PPIs. So you can switch to PPI. And in my practice, I typically switch to rabeprazole because that has a different metabolism than omeprazole and lansoprazole. So if you can identify that, you can also see if they have hypersensitivity. Are they responding? Are they noting symptoms every time they have a reflux symptom, despite the fact that the acid is being suppressed? So in those particular patients, I may prescribe them a neuromodulator. So it's pretty interesting that you may come to the gastroenterologist and you may leave with, more PPI or a neuromodulator or potentially a referral to behavioral medicine for hypnosis. So once again, tailoring the therapy to the abnormality that you know. There are even better ways to kind of define this now, and there's a lot of headway in terms of looking at these new machine learning tools to get better prediction models so that we can actually be better at predicting who's failing PPIs and the reason why. And these are some other things that we're looking at that are certainly improving this ROC curve in terms of sensitivity, specificity. I think one of the tools that I've been using a lot more often is that if I see a patient in my clinic who comes in with regurgitation as their primary complaint, in my practice, my first thought is, could this be rumination syndrome? In fact, that is a very common cause of regurgitation that is often misdiagnosed. And the misdiagnosis of rumination syndrome, which is literally a regurgitation that is voluntary, but the patient doesn't perceive it as being voluntary. They may have just learned that they need to evacuate their stomach because when they feel full, it's uncomfortable. So they learn this they learn this during development, sometimes when they're children. Eventually, sometimes it evolves into an eating disorder. But this rumination event is something that we can fix with diaphragmatic breathing. So if I can identify rumination syndrome, I will treat patients with diaphragmatic breathing right in my clinic and effectively treat them in 5 to 10 minutes. And this can be usually done or diagnosed with this manometry catheter, which is another catheter like we diagnose esophageal manometry motility disorders. But what we do is we give them a meal and we just watch them. And we look for these reflux events, and then we categorize them as either having rumination syndrome or something like this. So this is what a rumination event looks like. They compress their abdomen, they take a deep breath in, and they bring it up. And then you have them place their hand on their stomach, and then you can feel that they're doing it. And then you have them do diaphragmatic breathing. And when they do the diaphragmatic breathing, it completely stops. So this is my phenotypic expression of how I go through the patients. And really what happens with this particular paradigm, instead of sitting there trying multiple different PPIs, what we effectively do is we get right to the heart of the matter and get right into physiologic testing up front. And if you do physiologic testing and pH testing up front, in cost-effective models, you will be cost neutral at a year and dominate after a year. Because remember, GERD is a chronic disease. And unfortunately, these patients stay on these medicines inappropriately for 15, 20 years. So if you can actually do this, you will actually be cost-effective and reduce inappropriate PPI use, which is an important thing. Because as I mentioned, you could save $2.5 billion or more throughout the years. So when you come into my office with refractory reflux or seeing me for reflux, I can go in many different directions. Now, some of these are actually not FDA approved yet, and I just want to talk about them because they kind of make sense physiologically, and we'll probably see them eventually. Some of them are off-labeled indications that we use. But if you think about it, how many people use baclofen in the audience for something? Do you use it for reflux? Probably a lot of people don't. It's a common medicine. It's a muscle relaxant. There are many people who see me in my office and I put them on baclofen. Why do I put them on baclofen? We'll talk a little bit about that. Now, where are we with this group? And I'll tell you, it's a really hard group to study. So this was a study done by one of my friends, Stu Speckler. And what he tried to do was a randomized trial of medication versus surgery for refractory heartburn. And I'll tell you, trying to do a randomized controlled trial with a surgical intervention, in my mind, is nearly impossible. If I'm a patient and someone wants to randomize me to a surgery, I want to know what that surgery is. You know, I mean, this is something, they're going inside my body. I mean, in the United States, it's pretty much impossible. You know, there's not many patients that'll do this. Now, the caveat to that, this was done at the VA, where the patients are a little bit more amenable to these kind of things. But it's interesting because even at the VA, they were not able to enroll their target. So what they did was they were actually trying to randomize people to laparoscopic Nissen fundoplication, active medical treatment with omeprazole plus baclofen, or with a TCA, decipromine added depending on symptoms, or then just control, continuing on a PPI. And the primary outcome for this was a 50% or more reduction in their GERD HRQL, which is a GERD-related health quality of life indice at 1 year. So their target for their study was to enroll probably about 200 to 400 people. And that was kind of where their range is. And when they actually looked at it, after screening 400 people over almost an 8 to 10 year period, in the end, they only round up with 78 people. So far below their target sample size and their power calculations, because it was a difficult patient group. What was interesting, though, is that when we're actually going, why were these people failing or screen failing? Well, it was interesting because a lot of the patients got better once you fixed their PPI dose and you told them how to take it. So a good chunk of the people left because they actually, started taking their PPI and they were fine and they didn't need any escalation. And then another good chunk of these people, almost a third of them, actually didn't have reflux, had negative studies. So once again, it goes back to that thing that if you treat all of these people the same way, you're going to be mistreating or inappropriately treating a lot of patients who don't even have reflux. And it was interesting because when he looked at this study, in the end, what happened was that there was really only 25 people randomized to active medical therapy. And if you looked at it, most of the failures related because baclofen makes people sleepy. So baclofen works by blocking the belch reflex. And the primary mechanism of reflux is belching. Now, a great way to get rid of belching is to just put someone to sleep. Because when you lay flat, it's very hard to belch. And then when you're sleepy, it kind of turns off that central mediated reflex. And belching has a lot of similarities with cough. So baclofen can work with reflux-induced cough. And in fact, in my practice, that's the primary indication I use it for, either belching or cough. So if you have chronic belching and cough, you have a history of reflux, baclofen's a pretty good medicine. But it's horrible for heartburn, and it's horrible for regurgitation. So it's no big surprise that these people didn't do well. Now, if you look at the 27 patients who were randomized to surgery, in this very distinct group, they did pretty well. In fact, there were 18 successes, only really 2 failures per protocol and 2 by ITT, and then 5 failures by ITT. If you look at the screen fails from when they were actually in there, 1 was lost to follow-up, 1 moved from the area before surgery. But in the end, when you actually looked at surgery versus medical therapy for medical refractory disease, it was no big surprise that surgery was better. And surgery is a very effective tool for truly refractory reflux disease. And we send patients all the time for these surgeries. Now, what was very important to remember here, though, is that surgery is still not benign, right? So if you have the opportunity to use a PPI and you're doing great, you know, there's no reason to do anything else other than that. The risks of PPI are very minimal. Shouldn't be talked out of taking a PPI. Because if you look at it, even in this very small study, 1 out of those 27 people almost died, right? So reflux is a pretty benign disease. So this person was in the hospital for, you know, a pretty long time, at a reoperation. So right there, you know, the cost, just differential for a reoperation and a hospitalization, you know, that's like $30,000, $40,000. So if you look at how expensive that would be, you know, that really drives up the cost if you did surgery on everybody too. So in terms of that, we reserve surgery for the right patients. So if you look at this, the other thing that really gets, unfortunately, not addressed often enough, and sometimes it's just because talking to people about weight loss in clinic is delicate, right? I mean, we know that probably the best thing that you can do for someone with reflux is lose weight. And it doesn't have to be a lot of weight. But sometimes we find it hard to tell patients that they need to lose weight. And I think there is some finesse to that. You know, and I've seen people just tell people, you're obese, and they give them their BMI and say, you need to lose weight. You know, the other thing is that how I try to address it, whether or not they're obese or not, is I try to just let them know, listen, you know, one of the best things you can do is if you can lose 10 to 15 pounds, you may see a dramatic reduction in your reflux symptoms, because that applies pressure. And there have been studies that say even that small amount of weight loss can have a dramatic effect. And we've actually built in things where we use health coaches to help patients. And I think if you can get them to lose that 10 to 15 pounds, they'll do pretty well. A couple other things that have been pretty good are, you know, avoiding eating before bed. And I think there's some validity to that, especially when people have nocturnal symptoms. And then head of the bed elevation is really important. If you have refractory patients who have scleroderma, patients who have pulmonary fibrosis, you got to get gravity. Gravity is your best friend. So head of the bed elevation is extremely important. So for our lung transplant patients, we're doing that almost uniformly, recommending these lifestyle modifications, because that's when their lungs are at risk, when they're sleeping at night and they don't have gravity protecting themselves. Well, what are the other diet effects? Well, certainly we know that obesity will reduce strain reflux. It'll also reduce the acid pocket and a hiatus hernia. So it makes sense to lose weight. You know, there are all these other things that we advocate for. And I will tell you that I typically don't tell people to avoid all of these things. I tell them avoid triggers. So if something makes them feel worse, avoid it. Because what you don't want to do to patients is you don't want to make them scared to eat. You don't want to make going out to dinner an ordeal. What happens with many of these people, and we're seeing this, there is all these anorexia-like syndromes now that are related to people who are so focused on healthy eating and restrictive diets that it overwhelms their lives and they make everybody else in their family miserable. And this is a common problem. So I tried to be a little more lax here, and I say, listen, you can have some alcohol if you have reflux disease. But if you tell me that every time you drink red wine, you have bad heartburn, don't drink red wine. But if you don't have any problems, I'm not going to tell you, I mean, I'm not going to tell you you can drink excessively, but I'm not going to tell you that you can't enjoy an occasional glass of wine or a cup of coffee. You know, you're starting to reduce their quality of life by putting on all these restrictions. In fact, we used to do this thing at our fellows, end of the year fellows conference. We used to jokingly show one of our attendings anti-reflux diet. And in the end, the only thing you were able to eat was chicken and rice. Like if you really followed this diet, which was crazy. So, you know, this would drive down people's quality of life, and it's really not all that effective. Well, what about some of the other medical interventions? Well, as I mentioned, there are a lot of opportunities here to focus on the pathophysiology. And each one of these particular approaches addresses a different thing. Now, one of the things that I think people get shocked by is the relative potency of PPIs. If you look at the relative potency of PPIs, and if you look at pantoprazole, look at its omeprazole equivalent. So think about how we think about pain meds with the morphine equivalent. Well, we think about things in terms of omeprazole equivalents. This was a great paper by David Graham. And if you look at it, 40 milligrams of pantoprazole, which is the standard dose of pantoprazole that we use, is essentially a pediatric dose of omeprazole. It's equivalent to 10 milligrams of omeprazole. So you should not be shocked when your patient on pantoprazole is not getting better. So where I use pantoprazole is when I have someone with very minimal reflux, and it's almost like a placebo in many aspects, especially at the 20 milligram dose. So these are people when I'm trying to wean them down, or I don't think they have a great indication, but they won't stop their PPI. I'll use pantoprazole. I'll also use pantoprazole when people have side effects of bloating with PPIs and alteration in their bowel habits. They tend to tolerate it a little bit better. Look at what the most potent PPI is. Rabeprazole. Not very well marketed, but actually the best PPI. And this is, you know, in my mind, we've always known this, but it was always shocking that this was not used more often. And this is probably the hardest one to get when you're trying to get it through a formulary or prior authorizations. But the 20 milligram dose of rabeprazole is equal to almost double the dose of omeprazole. And if you're looking at even close, you know, stronger than esomeprazole and actually stronger than dexlansoprazole. So you have room to move with your PPIs if you choose to do that. And switching the PPI can be very effective here. And I will tell you, I never switch between omeprazole and esomeprazole or lansoprazole. These are all basically the same type of medicine. And if you're a hypermetabolizer, you're going to be a hypermetabolizer, all of these. I really make a switch to pantoprazole for side effects. And I go to rabeprazole if I want to treat a hypermetabolizer or someone who I want to escalate their acid suppression. And that's how I use my PPIs. There are some endoscopic therapies. There's a lot of debate on whether or not these work, you know, whether you're glass half empty, glass half full. And I think in the right patient, these particular procedures can be very effective. And they range from delivering a little bit of RFA energy to cause hypertrophy and kind of a reduction in opening at the EGJ, to actually these fancy suturing approaches. And then this new approach where they literally just cut out the entire top of the stomach, let it scar down so it creates a new anti-reflux barrier. I think the one that really kind of is the one that's most used right now is this TIF procedure, which is kind of an endoscopic fundoplication. And there is actually pretty good data. So once again, if you see someone who has one of these flat valves that are kind of like a 2-3, but there's not a big hernia, well, then if you buttress this and you suture this closed, these are people that could theoretically respond. And if you look at the randomized sham-controlled studies, it does effectively treat regurgitation. So here is a comparison between sham, so where people went down and pretended that they did the TIF and then came back up. And, you know, the number needed to treat is not great, but, you know, a 6 to 8 is not that bad. And I tell you, if you target the right patient, this would probably be even more effective. So if you look at the long-term results with this, pretty good. And that was one of the things we worried about with these endoscopic therapies. How durable were they? Well, we're starting to see that as advances are occurring in terms of this particular technology, it certainly is getting better and better. Now, another technology that's come out is the TIF kind of response in terms of surgery being less invasive, is the Linx device, the magnetic sphincter augmentation. So now this is surgery, but instead of actually doing a fundoplication where you're cutting down a short gastrix, you're flopping the stomach over, you're literally just implanting a magnetic ring that allows the sphincter to open and close, but resists it more. There had been products in the past that were more resistant and stiff rings that would erode through the wall and a lot more predictability. But this seems to be a little bit more pliable and distensible, and the esophagus tends to like that a little bit better than a stiff ring like a lap band or an angel tick prosthesis. And the nice thing about this is that it's easier to do. It's a little less invasive. You don't really destroy the anatomy as much. And it is reversible. You can take these out, although it's not as simple as you would think it is. And there is pretty good data, especially in regurgitation. This is a randomized trial against omeprazole at a very high dose, 20 milligrams BID. It's called the Caliber trial. And it wasn't a huge study, but once again, when you're doing randomized controlled trials with a surgical procedure, it's really hard. And when you actually look at these particular patients, you can clearly see that this works really well. And this looks like what you would typically see with conventional fundoplication surgery. You also see a pretty good reduction. Now remember, PPIs work really well at reducing acid, but the Linx device works even better in terms of reducing that overall acid exposure and burden in terms of the number of reflux events and the actual reflux exposure. So physiologic data show that it works really well, and it's very effective in refractory patients who are not responding to double dose PPI therapy. Now, it does have some drawbacks. Just like any surgical procedure, there might be some complications like dysphagia, where people feel like there's an obstruction there because there is an obstruction. And you have to be very aggressive with these patients. You have to encourage them to eat. There can be erosions through the wall where the actual ring will erode through the wall, but the rate of doing that is still pretty low. So when you actually look at that, it's on the order of 0.3%, which is much less than what we see typically with these reoperation rates with fundoplication. So once again, I think we found something that works. It may be reversible, and as we're accumulating more and more data, I think we're getting to the level where we feel more comfortable with this device, and it's starting to become more of an important part of our practice, although it is self-pay though. So that's the problem with the device, that insurance coverage is really bad, but just like anything else, we hope that eventually that'll get better. So let's get back to that VA randomized trial in refractory GERD, and let's focus a little bit more on these 99 patients that screen failed because they just didn't have reflux. So what do you do with those particular patients? Well, as I mentioned, you can place them on a neuromodulator. And how do neuromodulators work? Well, think about coming to a GI doctor's office with the complaint of heartburn or chest pain, and then I tell you that I want to put you on amitriptyline or Celexa. You're probably going to be a little bit mad. You're going to think that I think you're crazy, that this is all in your head, and if you're not careful, that experience can go awry. And you have to be really careful on how you describe this scenario to patients. So what I typically do when patients have what we believe to be functional chest pain, functional dysphagia, globus, or functional heartburn, meaning that there's not an overt pathologic or an objective complication that you're seeing, is talk to them a little bit about the brain-gut action. And how I typically start the conversation is if they're wearing glasses or a jacket or a watch, I'll say, can you feel your watch? And they'll usually look at me like I'm crazy and say, well, of course I can feel my watch. And I'm like, well, could you feel it a few minutes ago? And they're like, no. And I'm like, well, why? Like, well, because I wasn't thinking about it. Well, I tell them, do you know your GI tract is moving all day? And your brain all day has to shut that sensation down. It's amazing how little we understand about the negative effect of the brain in terms of the inhibition of sensation. Like, why do I not feel my esophagus moving? I mean, it literally is pushing a piece of food around my heart through my diaphragm. Why do I not feel that? Because your brain shuts it off. But every now and then, something happens where your brain starts to think, hey, some food got caught there. I got to watch this. And then it starts to sense that normal physiologic response. And that's what's happening in you. This is all in your brain. Everything's in your brain. All pain. If I, take a hammer and hit you in the knee, if you didn't have a brain, you wouldn't feel it, right? So I go through this little description, and then I tell them, and how we like to treat this is in two ways. One way is I can give you a neuromodulator. I never tell them an antidepressant because then they get that stigma. I say, I can give you a neuromodulator that will affect the firing and the threshold of you sensing this. And what this will do is it'll raise the threshold or it'll reduce the firing. And we typically use these medicines in diabetic neuropathy and these neurologic pain disorders. So, and I tell them, the easiest ones to use are these old school antidepressants that we don't even use at doses of antidepressant, but they actually help with this. They help with neuropathic pain. And I typically tell them, you know, I usually use either amitriptyline or Select, so they're kind of the most well-studied. And that's how I get them to buy into that. But I'll tell you, I give them the other alternative, which is something that, you know, I have to say when I first heard about it, I thought it was crazy. So the other alternative I give them is hypnosis. And I will tell you that this literally changed the way I practice. Because I will say that probably if you come to see me, you are much more likely to leave with a prescription for hypnosis than you are for a surgical procedure or any medical intervention. And I'll tell you, even if you have refractory reflux, this works. And how it works is it taps into that inhibitory function. It just shifts your attention away from the symptom. It makes you forget about it. And it's interesting because we've had refractory disease like a lump in the throat, globus sensation, treated with hypnosis, 75, 80% effective. Some people say, well, that's a placebo. I don't really care. I mean, you know, if they're not focused on this and their pain and discomfort is better and it has no side effects, why does it matter? So the bottom line is that we treat the majority of our functional heartburn, functional dysphagia patients. I'd say 80 to 90% of the people opt in for hypnosis now. And this is a medical delivery that can be delivered on a web-based format. You don't even have to be in the same room to do this. There are web-based platforms that can have hypnosis. And there are multiple people being trained across the country now in GI psychology or gastropsychology. And this is becoming a very important component of our armamentarium to treat these particular patients. Now, there are some other medicines that if you think about it, if you're feeling things and you have bad tissue resistance, there are some of these medical devices, and we have to call them medical devices because they're actually components of different molecules and nanotechnology that'll actually coat your esophagus. And this is something that's available all throughout Europe that's not available in the United States, but it's a pretty benign component. It's hyaluronic acid and chondroitin sulfate-based bioadhesive. And as I mentioned, to me, it's a medicine, but you have to call it a device because it has this combination here. But it can help some of these patients, and it's completely benign. So I think we're starting to see a lot of these particular different constructs. So in the end, I think the important part of this particular presentation is to realize that GERD is a very complicated disease state. When you look at GERD in terms of what drives GERD and healthcare utilization, certainly the pathophysiology is driving the symptoms. And then, of course, some of this stuff that drives the neuropathic problem, this brain-gut interaction is important. But probably more important than anything is the cognitive response. If you think about it, you have two people. One person sitting at home has 8 out of 10 chest burning. They run to the emergency room. They think they're dying. They've had 2 stress tests. It's not their heart, but they keep running to the emergency room. You have the second person, same scenario, 8 out of 10 burning, happens, takes a couple of Tums and goes back to sleep. One person dries up a $5,000 bill. The other person spends 60 seconds. And this is really one of the most difficult things we deal with in gastroenterology and also symptom-based diseases, is helping the patient deal with their symptom in an effective way. And one of the added benefits of sending patients for hypnotherapy, especially when you're using a psychologist, is that they use cognitive behavioral therapy to talk these patients down and to reduce unnecessary healthcare utilization. Because you can do everything that you can to fix the plumbing, the brain-gut interaction. But if you don't fix this cognitive response, you're still going to cause all of this increase in healthcare expenditure and a reduction in quality of life. So when I treat and I effectively manage these patients, I go through this stepwise approach on all of these particular patients. And I'll tell you, one of the things that I like about this is that it's very Bayesian. Does anyone here play Texas Hold'em poker? Anyone in the audience? Well, if you play Texas Hold'em poker, it's really Bayesian thought and logic. You take cards and you think about what your pretest probability is that you have the best hand, and you make bets on that. And that's literally what we do in medicine. It's Bayesian logic. You get a good history and physical. You kind of take a good guess at what you think is going on. You give them an empiric trial. If they fail that empiric trial, you use that information to inform your next step. I get that upper endoscopy. It's kind of like the flop. I get more cards. Do they have a big hernia? Do they have esophagitis? And if they have that, well, my pretest probability that they have reflux is pretty high. I'm all in. I'm going to bet a lot of money. But if that's negative, I'm like, hold up, this may not be reflux. I got to get reflux testing. And then I get the reflux testing, which is your turn card, which is where everybody loses a lot of money when they play poker because they misinterpret the turn card. And if that turn card tells me that this is not reflux, I fold and I send them for hypnosis. But if it looks like it's reflux, then I feel comfortable that I'm going to send them for surgery. Now, there's something called a bad beat in poker. It's when you make all the right decisions, but things don't go well. So in this patient who I go through the whole paradigm and they have a positive reflux study, they're not getting better on P, they're a perfect candidate for surgery. I send them for surgery and they have a bad outcome. And it's not because the surgeon did anything bad. Esophageal surgery is some of the hardest surgery that is done. It's a very complicated area that's moving up and down, and trying to recreate that is very difficult. So you can get a bad beat. And one of the ways to prevent that is to get a manometry and make sure everything looks the right way, because you don't want to get a bad beat that was your fault. You want it to be something that just happens because of the natural, odds that surgery can go bad in some people. So if you follow through this algorithm using a personalized approach and using Bayesian logic, you can do the best thing for your patient, which is target their therapy. Because not everybody with reflux needs a PPI. Not everybody needs surgery. And there are many times I can effectively get people off medical therapy and treat them with hypnosis and improve their quality of life. So my key messages for you at the end of this talk is really identify those important abnormalities, the things that will effectively change how you treat people, their physiology, their anatomy. Always modify diet and encourage weight loss. There's no excuse for not doing that for someone with reflux. Even if they're doing well on a PPI, you could reduce their PPI dose or even get them off PPIs. Always use the least invasive approach first. Never go right to something invasive, because we have a lot of opportunity to improve this without going to surgery. Because once you go to surgery, you pretty much crossed the bridge that you can't come back from. Because if they need a reoperation, the success rate of that is less. And those are some of the most difficult surgeries. And then and this is something that I think we always think about. Complementary treatments are not a failure. If you do a surgery and someone needs a PPI to become asymptomatic again, that's not a failure. If the patient's asymptomatic, you've succeeded. Similarly, if I can't control people with medical therapy and I need to encourage weight loss and then they lose it, it's not a failure of medical therapy. It's a treatment response that needed augmentation. And I think so many times we think about using another therapy or getting another diagnostic test as a failure. Well, if you get 3 diagnostic tests and you get the right answer, that's not a failure if you didn't know after one and you made a wrong decision. So that's something in medicine that I think we've really kind of stepped back from, but realizing that complementary treatments, especially in the esophagus, are not a failure. So with that, I'll end, and I think I have a little bit of time for questions. Thank you very much. Yeah. So thank you for that, because it's a nice segue into a book I wrote. It's not a great book. But it's the Virtual Integrated Practice Unit. And really what it is, it talks about, how new platforms are shifting healthcare and utilization. And if anyone's been fortunate enough to hear Mike Porter from Harvard talk about the integrated practice units and the benefits of it, it's really important, when you start to think about how telemedicine, how all of these things are going to change the way we practice. And one of the things that we actually look at here is development of these virtual communities that are going to help our patients. So one of the things that I think is really important, and this looks really complicated, but actually in essence, it's not. What I think we're going to need to do is rely on these communities where we have health coaches, dietitians, psychologists, who can really effectively provide these treatments without actually being under our jurisdiction. So where we can refer these patients to these networks, where they can meet people and they can pick a health coach and a psychologist they can't enter that community unless they have the appropriate credentials. But we don't have to worry about that, because yes, if I have psychologists seeing patients in my GI clinic, I'm going to lose money. If I have dietitians spending an hour with a patient going over their diet, I'm going to lose money. But a dietitian that has no overhead virtually can actually survive and do quite well. So I think there's going to be a lot of these opportunities using virtual platforms and telemedicine to actually get better care for our patients. As I mentioned, you can do hypnosis online. In fact, many of my psychologists do the majority of their work for outside referrals via Skype. So we don't have a way to really reimburse it just yet, but that's going to happen. If you look at all these archaic rules for telemedicine in this Social Security Act 1834, I mean, those are going to be torn down, because patients want this. They don't want to come to their office. They want this. And unfortunately, this is their portal. Everyone has one, and this is how we're going to practice medicine. And we can fight it, but if we don't, if you fight it, there are going to be plenty of people who are already not fighting it, who are not really doctors, who are taking advantage of this and taking this huge chunk of our patients away from us, and they don't know what they're doing. Go online and look at these sites like Lemonade, Roman. I mean, these are ridiculous. They're prescribing medicines to patients. I mean, we need to push back, and we need to engage in this. So I think it's a great question, and I think we have opportunities to do it.
Thank you. Slightly, maybe a deviation from the focus of your talk, but what is the major threat of reflux to the patient? What is the worst thing it can do to them?
Well, certainly, when you think about it, most people it's benign. And I always try not to be alarmist, because it is a risk factor for cancer. In fact, there's very few people that I've ever seen in my life who have adenocarcinoma, and when you really talk to them, didn't have really bad reflux or some essence of reflux or anatomy that would be conducive to reflux. So reflux is definitely a risk factor for cancer. The problem with that is that you can significantly reduce someone's quality of life by telling them they're at risk for esophageal cancer. In fact, I had a case, and this is not that this was a plant or anything, but literally I had a patient who I was taking care of very effectively for many years. He had an endoscopy with one of my colleagues because I was out of town. He biopsied his squamocolumnar junction. It came back with intestinal metaplasia. He was given the diagnosis of Barrett's esophagus. Now, I would push back and say that I wouldn't even call that Barrett's esophagus. I would call that intestinal metaplasia GE junction, which is a much lower risk of cancer. Still a risk, but much lower than Barrett's esophagus. This guy went from being completely asymptomatic to feeling everything in his chest and was miserable. So, on one aspect, you see these things where this could be something serious. It could be cancer, and it drives people to come see the doctor. But it also screws up their quality of life because they get so fixated on, they're so deathly afraid of this cancer, which is really a killer. So cancer is certainly something that can happen there, and I think it's important. But I actually think that the thing that we haven't touched upon enough is microaspiration and lung disease. I think there are a lot of people out there, and we're seeing them now in their 70s. These people come in 60, 70, and they have horrible lung disease. And, they no real reason other, but they've had a long history of reflux. And I'll tell you, I actually think that there is a definite loss of pulmonary function that is related to reflux. And I think the perfect model for that is our lung transplant patients. You can clearly see that the patients after lung trans who do worse are the ones with bad reflux. So I think there is that idea that there's this undertow or, below the iceberg, the iceberg under the water, that may be this pulmonary part that we're kind of just ignoring. We're not appreciating. And I do think that that's something, but certainly cancer. But I really try, I always tell patients when they come in and they have that, even if they have Barrett's, I said, I promise you, you will not die of esophageal cancer. I said, you've already done the most important thing that you possibly can. You've come to see me, you've gotten your endoscopy, you're going to be in a surveillance protocol, and no one dies of esophageal cancer if they're my patient and they're in my surveillance protocol. So you've already done the first most important thing. And I think that's really important because people are scared of esophageal cancer. And when you give them that they have this time bomb in their body, it freaks them out. And I think you have to be very cognizant of that. So I try to temper it a little bit, but I certainly, it's still a risk that I don't ignore.
Yeah, one of the things I learned from you that I think the audience benefit from is an understanding of what things they can ask when they're initially evaluated to really look for things like information and other elements.
Yeah.
What are those things really that they should do?
So it's not so much asking. I think, it's kind of funny to me that if you look at gastroenterologists and if the students who rotate in gastroenterology and the gastroenterologist sees someone with, heartburn, regurgitation or dysphagia, you got to watch them eat and drink. So one of the things that, I have a glass of water in my room and, have like some crackers, graham crackers or something. I like to watch people eat. I mean, it's kind of like, listening to their lungs if they have shortness of breath, I mean, if, it's crucial to your exam. So I think by just watching people eat, I can pretty much figure out most things, so if they have regurgitation, I'll bring in something that makes you regurgitate. And they'll, why? Because, I'm not always on time. I'm always behind a little bit. They'll finish that meal. I'll walk in the room and they'll be regurgitating. I'm like, God, you have rumination. You put them on that chair, on the table, you teach them diaphragmatic, you see me teach people diaphragmatic breathing right in my clinic, and you can stop it immediately. So I think it's really crucial if someone comes in with esophageal symptoms to watch them at least drink some water, because even like with dysphagia, if they start coughing when they're drinking water, they don't even need to see me. They need to see a speech pathologist and get a modified cookie swallow. I don't know why they're wasting time with me. They don't need an endoscopy, but that's the knee-jerk reflex. So I think really focusing on watching them eat, getting a good evaluation of that. And then really just, kind of seeing, I think the other thing too, that when I'm thinking about people with complications, I always ask them, how are you sleeping? And then if their partner comes with them, I always ask them, are they snoring at night? Do you see that they're restless? Is there gurgling? Because those are the things that I really worry about. Because that's when they're at jeopardy and most vulnerable. So the pulmonary complications. But yeah, so watching them eat is something that's not done very often in clinics.
One question we have from Midtown. Hypersensitivity esophagitis seems like a diagnosis of this disease.
Yeah.
What's the future research heading for this?
Yeah, so it's all of these problems, they come out of like really poor understanding and poor technology. So hypersensitive esophagus just means we see that you have a lot of reflux events, and then more often than we would see with just random chance based on a Fisher exact test, that we see that you hit the button when you have a reflux event, that you have a symptom. Now, there's a lot of flaws to that approach because, you can imagine if I have a symptom, I may, oh my God, I forgot to hit the buzzer, right? So there's a lot of, things that people don't hit the buzzer at the right time. But if it's positive, and it's not by chance because you do statistical models, then it's probably pretty real. So this person is sensing something that's physiologic. I actually think that some of the better research is going to really focus on functional MRI and looking at these places, especially in the prefrontal cortex and the anterior cingulate gyrus. That's really where a lot of these kind of visceral effects occur, and getting a better understanding of those particular aspects and how we can modulate that. And whether we modulate it with behavioral therapies or neuromodulation is something that might affect it. I also think that our understanding of the tissue resistance and those tight junctions and how the cells spread apart, I think really needs to be focused on. in a much more detailed way. We know that people, when they have tight junctions that start to spread apart, are more likely to sense heartburn. And when you treat people, they close, their heartburn goes away. I think we need to be a little bit more cognizant, or at least focused on those tight junction proteins and how they affect that barrier function. Mm-hmm. Yeah, so typically what happens is the first session is contraindications. PTSD, or early childhood trauma or dramatic trauma in their life, is something that if they have that in their past, you don't want to do hypnosis because it can come back up and stuff. So, you know, they get screened for that, and then they learn diaphragmatic breathing. Diaphragmatic breathing should be done in almost every patient with a GI problem, because what it does is it alters the sympathetic tone. Your heart rate variability improves. You're more able to adapt to stress when you do this. So they teach them diaphragmatic breathing during that first session, and then they introduce the concept of hypnosis. They also screen them to see whether or not they'd be a better candidate for cognitive behavioral therapy. So after that screening, the second visit is focused on, you know, the actual hypnosis, and the metaphors that they use are varying. I actually helped them do the metaphor for globus, which is a lump in the throat. So globus, which used to be called globus hystericus, because in the old days, they used to think a woman's uterus was in her throat, which now they figured out was wrong. And just as many men get it as women. But now it's just called globus. And it's really this kind of vexing sensation that you have a lump in your throat. And it's very common. It's like 5% of ENT visits. And really what it is it's probably this perception of this defense mechanism of the upper sphincter to prevent you from aspirating. You can see with reflux, you can see with motility disorders. So what we did was we had them focus on an ice cube melting in their throat. So whenever they would feel this, they would visualize this ice cube melting in their throat, and with that, the symptoms going away. And they practice this. And many of those patients get better in 2 to 3 visits. Some it could take 6 to 7, and then they're usually sent now on a web format with these, you know, metaphors and these scripts that they can, if they start to get the sensation again, they can just hypnotize themselves, and they can go home with this, and they can do it. And there'll be patients I see, you know, 3 years later said, oh yeah, you know, I had to do it a little bit ago just as a refresher, but I'm back and I'm fine and I'm doing okay. And really no side effects. It's pretty amazing. All right, well, thank you very much.